Today I'm going to talk about meningitis. Meningitis is an infection of the meninges. In most cases, it is caused by a bacterial or viral infection. In rare cases, it can have a non-infective cause. Viral meningitis is more common and it's self-limiting. Bacterial meningitis is more serious and can lead to death if not treated. There are many signs and symptoms of meningitis. Typically, it presents with signs of sepsis and signs of meningitis. Of course, meningitis can lead to sepsis, so we must be on the lookout for signs of sepsis from the offset. Meningitis typically presents with headache, neck stiffness, and fever. A patient may prefer to lie still. The patient may also be vomiting and have photophobia. In infants, the symptoms are non-specific. These include poor feeding, high-pitched cry, and bulging fontanelle. Only if meningococcal meningitis is present, there will be a non-blanching petechial rash. Meningitis can affect the very young and old. People who are particularly at risk are those who have had spinal procedures, such as surgery to the spine or shunts. In exam questions, you may be asked about two signs commonly associated with meningitis. Brudzinski sign, which is flexion of the neck, will produce reflex flexion of the hip and knee. The second sign of interest is Kergnig's sign, where there is pain when the hip is fully flexed and the knee extended. Now on to the causes of meningitis. In neonates, the most common cause is group B streptococci. This is because these bacteria normally live harmlessly in a woman's vagina and can be given to the baby during birth as the baby moves through the birth canal. The three principal causes of bacteria can be remembered by the mnemonic NHS. Neisseria meningitis or Meningococcus pneumonia, Haemophilus influenza, and Streptococcus pneumonia, also referred to as pneumococcus. Neisseria meningitis is very responsive to penicillin. The two other bacteria I have mentioned are not as responsive. Streptococcus pneumonia is a gram-positive diplococcus. Haemophilus influenza will grow in chocolate agar and smells very distinct. Neisseria meningitis is a gram-negative diplococcus. Again, this bacteria will occur in pairs. Serotype B is the most common form of Neisseria meningitis, as serotype A and C are reducing due to vaccination. And we talked about how typically you see a rash with this meningitis. The rash tends to indicate sepsis, where the infection has got into the blood and the rash is a response to this. In 6 to 60-year-olds, Neisseria meningitis or meningococcus is the most common. After 60 years, strep pneumonia is the most common cause of meningitis. Investigations. Well, meningitis is a very serious condition, so we have to act promptly. Typically, a lumbar puncture is done, but of course we must consider contraindications of lumbar puncture. And if a contraindication is present, a lumbar puncture should not be performed. So a full blood count and routine blood tests should be done, as well as coag and blood cultures. Ideally, these tests should all be done before antibiotics are started. But if a patient is very sick, you can go with the antibiotics before lumbar puncture. A common exam question is to differentiate between a viral and a bacterial meningitis. Now, when you get the CSF fluid from the lumbar puncture, you will be looking at a range of different values: lymphocytes, neutrophils, the amount of protein, the glucose, and the color. In viral meningitis, we classically have clear CSF fluid with raised lymphocytes, and the neutrophils will be normal, as this is a viral infection. Protein will be elevated, but glucose will be normal. In bacterial meningitis, the CSF will not be clear but cloudy, and the neutrophils will be increased, but the lymphocytes will be normal. As this is a bacterial infection, we get the neutrophils increasing and not the lymphocytes. The protein will be elevated and the glucose low. You may be asked in your exams, how is TB different from other bacterial meningitis? Well, you have to use the gram stain for starters to identify it, and also it will give an increase in lymphocytes like viral meningitis rather than neutrophils. A CT scan can also be done in meningitis, but it is not indicated in all patients. In fact, it is only indicated in certain conditions. For example, if a patient had lateralizing signs, seizures, or a HIV infection. Now, how might meningitis be managed? If you're a GP and you see someone with meningitis, in particular, if this is suspected meningococcal meningitis, in other words, the patient would have a non-blanching rash that you'd think, oh, this is this type of meningitis, they should be given an IM or IV injection of benzyl penicillin. In less than 3 month olds in the hospital, they should be given cefotaxime plus amoxicillin. The amoxicillin will cover listeria. Over 3 months, the patient will be given ceftriaxone. In pneumococcal or Haemophilus influenza meningitis, dexamethasone is given with the antibiotics, as this reduces the risk of neurological damage such as cerebral edema and hearing loss, and this is typically given as 0.15 mg per kg. In Streptococcus pneumonia, vancomycin can be added. This is very useful in penicillin-resistant pneumococcal infection. Now, lastly, I will talk about post-exposure prophylaxis. Meningitis is a disease we have to notify public health. And if a patient is in contact with other people, it is important to treat them as well. So if a patient has meningococcal meningitis and they have been exposed to other people on close contact household contact, these people that they were in the house with are at risk of developing the meningitis. And the risk is high as 7 days before they've developed the condition. So 7 days before they've got the headache, the vomiting, the photophobia. And these contacts are typically given ciprofloxacin, and it is given as a single dose. This is typically used for meningococcal meningitis, but for pneumococcal meningitis, no prophylaxis is generally given. Of course, there are some exceptions to this, but this is beyond the scope of this video. Thank you all for listening. I hope you enjoyed the video, and if you did, please don't forget to like and subscribe to this channel for more medical education videos.